Hi, this is Neil Hansen, and I'm taking you through a CT cystogram. So why would you get a CT cystogram? Well, usually it's to evaluate for a bladder leak or a bladder injury. In this case that I'm going to show you, you can see that there was a trauma. It was a complex pelvic fracture, and there was a suspicion that the bladder was injured. Also, we'll do these, for example, after a hysterectomy, if there was some concern that the bladder or distal ureter might have gotten injured during a operation, or after a transplant, say a kidney transplant, where there was worry for a leak at the ureteral anastomotic site. These are all multiphasic studies, and uniquely we give contrast via the Foley catheter in place rather than intravenously. I'll note though that usually in these cases the Foley catheter is in place prior to coming down to radiology. Usually we will have the urologist or clinical team put in the Foley catheter, and then we merely just put the contrast in via gravity drip. For a CT cystogram, if you've never done one, I use the kind of analogy of taking a car trip. When you're instilling contrast, how do you know how much is enough? Typically it's 150 to 200 cc's, but I tell people that imagine you're on a car trip, and as your bladder fills up, I want you to tell me the point at which you would stop the car and pee on the side of the road. That's how full we want it. For children, people use the toe curl rule. So if you're watching a kid and their toes start to wiggle and curl, that's about the time when you can stop. Obviously, we don't want anybody to be in pain or cry, so if you can't make it to 100 or 150 and the patient can't tolerate it, just stop. But get as much in as you can. So when we do these studies, the first thing you do is you do a non-contrast CT to get kind of a lay of the land. Pelvic fractures, especially if there's displaced fracture fragments, can occasionally mimic extravasated urine, and so you want to have a lay of the land beforehand. Then we get an image of contrast installation. So after contrast is put into the bladder, we take an image, and you can see here that there is in fact a leak. So if we zoom in on the bladder here, you can see along the left aspect of the bladder, some of the contrast we put in leaked out laterally to the left, adjacent to the pelvic sidewall. So this is what a bladder leak looks like. And you know that it's not just an artifact or a hematoma or something like that, because this was not present prior to contrast administration. We then empty the bladder out and then scan again, and typically leaks will remain persistent. I've got a couple leaks that were seen best on this post-evacuation image, and so it's important to drain everything out, take another CT scan, and look for small subtle leaks. Typically, like I said, leaks will remain on this post-evac image, making them even easier to see without the contrast in the adjacent bladder. Of note, if you're ever protocoling a study, occasionally teams will ask you to clamp a patient's Foley catheter and to do a CT cystogram, and I'll just have you know that that's an inadequate way to do a CT cystogram. You really have to instill via gravity drip and achieve a pressure head. You're at risk of causing a false negative study by just clamping a patient's Foley catheter, especially if their renal function is tenuous, because the kidneys, native kidneys, even if they're working functionally well, cannot fill up the bladder soon enough to get an adequate CT cystogram image. So sometimes people are tempted to cheat by clamping off a Foley and getting a delayed image, and I'll tell you that's just inadequate. Put them through a full CT cystogram protocol for optimal visualization of any bladder leaks.